bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, the McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, and the Holland Bloorview Children's Rehabilitation Hospital Foundation. We would also like to thank the following Keystone partners for their ongoing contributions that support all of CAFC's programs and activities. And we'd also like to thank Mallinckrodt Pharmaceuticals for supporting this three-part patient safety mini-series. All three episodes in this series are available on CAFC's Knowledge Exchange Network, and we hope you will check them out in case you missed them. We'd also like to invite you to join our colleagues from Mallinckrodt at the CAFC Annual Conference in Quebec City. On October 19th, Mallinckrodt has sponsored a breakfast session where we will hear stories and learnings from the front line, the impact of interdisciplinary teamwork on patient safety and healthcare practice. This session will feature Dr. Keith Barrington and Ms. Sophie Gravel from the CHU St. Justin in Montreal, and they'll be joined by Ms. Barb Farlow from Patients for Patient Safety Canada, and they're going to lead a conversation about what your role might be in the future of patient safety. And for more information on that session and any other conference information, you can go to www.conference.cafc.org. All right, so hello and welcome to today's episode of CAFC Presents. My name's Doug Maynard, and I'm the Associate Director at CAFC, the Canadian Association of Pediatric Health Centers. And today's webinar is titled Reimagining the Roles of Patient Safety, Quality, and Patient Experience. And we have an excellent panel today. And once again, as I mentioned earlier, I'd like to mention the CAFC Annual Conference coming up in Quebec City from October 18th to the 20th. Everyone's invited to join us in Quebec City, where we will learn and share our expertise in finding solutions in children's healthcare. And once again, lots more information at www.conference.cafc.org. All right, so now it's time to get on with our panel. As I mentioned, this is part 3 in what was a 3-part series on patient safety that we started, sort of separate from our monthly patient safety collaborative webinars. And when we started this mini-series with Dr. Trey Coffey and Dr. Kaveh Shojania back a few months ago, it was really a discussion on what's happened in the patient safety movement, starting with they gave us a real great recap of the past 15 years of the patient safety movement and really gave us some opportunities to think about where the movement is heading now. And it was really from the perspective of, 15 years ago, patient safety was on the tip of everyone's tongue. And 15 years later, we were wondering, has the patient safety movement sort of been compartmentalized into the world of those with the words patient safety in their job title, or is it really still on the minds of everyone in the system? And we had a great conversation about that. Then we had Wayne Ho and Kim Streitenberger from Healthcare Human Factors and from ISMP Canada talking about how we moved from building on the clinical interventions that we started with early in the patient safety movement to looking more at systems and at the people that are part of the system. And now we're really going to do what I think will be something a bit outside the box. You're not going to see PowerPoint presentations and that sort of thing on the screen today. As the title of this session says, we are going to reimagine the roles of safety, quality, and patient experience. And I really hope you will join us on this journey. We've got 2 great panelists who are really just going to start a conversation. They're going to have a conversation amongst themselves and sort of set the stage, and we really hope that everyone in the audience is going to take an opportunity to provide your comments and tell us what you really think about how we can reimagine the roles of patient safety, quality improvement, and patient experience. And so I think it's really going to be a great conversation. I'm excited to get started here. So I'll introduce our panel. First off, we'll be hearing from Hugh McLeod. And Hugh is certainly needs no introduction, I'm sure, but Hugh is the former CEO of the Canadian Patient Safety Institute, as well as many other senior positions with ministries of health and other government and senior health region positions across the country. His bio's up on the screen there, so lots of great information there. And joining Hugh is Leslie Thompson, who many of you may know from lots of presentations that she's done. In particular, I heard her on White Coat Black Heart art talking about some of the things that they've done at Kingston General around patient experience. The session with Brian Goldman, who is a former presenter on CAFC Presents. But Leslie Thompson is the president and CEO of Kingston General Hospital, and she's also the chair of the Canadian Foundation for Healthcare Improvement. So we've got some real expertise in thinking at the high level, thinking outside the box, and really I think they're going to lead us in a really excellent and informative conversation. So I'm going to hand the virtual podium first over to Hugh McLeod. Over to you, Hugh.
Well, thank you very much, and thank you for the invitation to be with all of you today through this wonderful electronic medium. The advertisement for today read as follows: join us in this final installment as we look at what might be an alternative future for healthcare, and we think outside the box and reimagine the roles and interplay of patient safety, quality improvement initiatives, and patient experience in building our healthcare system. After 35 years of healthcare and experience, I view that I am a lifelong learner, and for me it boils down to a single key question that both formal and informal leaders need to address and answer each and every day. And what is that question? Well, for me the question is, what do patients and residents need, and how can the system collectively respond? And while the question is simple, the issues that need to be addressed are far from simple. They are complex. Why? Well, because executives, managers, professionals, and frontline staff have really developed their careers in a silo-centered, bureaucratic model of healthcare delivery, driven far too often by the provider's control of healthcare services and not the consumer's perception of value and need. In our often bureaucratic command and control hierarchies, unfortunately, behavior is often honed to operationalize one's private and ego-pushed formal authority. I suggest in order to actualize a future with focused sustainability within healthcare, all leaders will need to model, exercise, emphasize, and develop and promote new collaboration skills. And not just collaboration with the providers of the organization, and I'm sure Leslie will cover this, but also collaboration with the patient and the families who trust us and use the services that we provide. So significant change, from my view, cannot occur on patient safety and quality unless leaders, again, both formal and informal, empty out the models, assumptions, and directives that no longer have merit or meaning to advance the patient safety and quality agenda. I believe when leaders remove all the debris, they will be rewarded with a necessary space that allows for a new vision of patient quality and patient experience to form. This form of purging requires discipline and courage. Leaders must be disciplined enough to resist knee-jerk reactions and bring courage to separate old patterns, structures, and processes which, given our new age of speed, technology, the patient and the resident being able to seek information online. And success, I believe, will come if leaders at all levels admit to themselves that they do not have all the answers and are motivated to ask the right questions. Because for me, questions must be asked and focused on accountability, self-reflection, honesty, and purpose. So here are some examples of questions that I believe we should be asking ourselves each and every day. What results do you want to create to make the healthcare system realize its purpose as a patient, as an individual, as a team, and as an organization? And what will the future look like? Its vision for achievement. And to do that, what relationships will you have to build to get there? And the real tough question, how is what you are doing right now helping you get there? And I guess the other side of that question is, what is hampering you in achieving this right now? Often, we don't speak to the real issue, which is, what are you afraid of losing? And what might you gain by doing something different? How will you work with others to adopt the changes in practice that are necessary to advance patient safety, quality, and the patient experience? For asking the right questions also breaks the ritual of conversations that take place. Again, I believe leaders must ask the right questions at the right time, and the key is the framing of the question and the timing of its asking in a manner that creates commitment to continuously learn and improve the quality and patient safety experience of those that we have the privilege to serve, and that is the patients and families that come through our doors. So with that as just a very brief opening, Leslie, I will turn to you.
Thank you very much, Hugh, for a great start. And it is my absolute pleasure to be part of this conversation today with all of you. I'm going to build on something that Hugh was talking about related to the importance of seeking new ways to collaborate and engage in creating a future that is one that we can all embrace. And in my view, the work that is underway now in Canada, across many parts of Canada, in my own organization here at KGH, and frankly across the world around patient engagement and the meaningful involvement of patients and families, is one of the features of the journey toward a kind of a more radical redefinition and refocusing on quality and safety that I think is essential for the Canadian healthcare system. So here's my premise, that really, there's a lot of big things happening in healthcare and around us. The context in which we work is vital to understand. It's not the new Apple Watch, the 3D printer, or even the advent of personalized medicine. To me, the most critical and disruptive force of change is people power. And it's the people power that's really starting to shake the very foundation on which healthcare systems around the world have been built. And the role of hospitals and professionals, as Hugh has alluded to, have really been iconic features in a landscape that's been purpose-built with, when I imagine, the way we've been, it's really been purpose-built with castles, moats, and defense artillery. Terse protection, often under the guise of patient protection, has been so ingrained in the way that we do things that few recognize kind of how we have evolved. But I believe that the reimagining of the current and future state of health and healthcare is about reimagining the way in which we can work together on the premise of people power. So what does that mean? What it means is a new world order emerging where it doesn't wait for people who are typically called, quote, experts to figure things out on their own. It's not one that gives higher status to professional experts just because they have an MD or an RN designation after their name, or even an H on a hospital entrance. This new world order acknowledges that it's the experience that people and patients who are living with their experience, that what they bring to the table is just as important as the knowledge that professionals have earned through their immense training and experience. And in this situation, value is created when people with this different and complementary areas of expertise are working together for a shared purpose. I am reminded, I'm active on social media and I've had many engaging conversations with patients and families throughout the world, and am reminded by them regularly that every year that a person living with something like Parkinson's disease or chronic kidney disease every year that they spend 1 hour in healthcare, they spend 9,000, 10,000 hours in self-care. And it's the patients and families who are part of this lived experience that are becoming the real voices of change, and I believe that they deserve as much respect and inclusion in the new world of quality and safety and health and healthcare as those of us who have other experience. In fact, a patient experience advisor at KGH, Karen Nicole Smith, reminds me, and she calls this notion of, she sees herself as a lived experience expert. And I love that notion because I think that that is the notion that really needs to become mainstream. And once you start to reimagine the role of and the contribution of the patient and family as lived experience experts, everything starts to change from there. At KGH, we have been on a journey that a number of you may be familiar with, where coming out of probably some really difficult situations where we had to address some very challenging operational and clinical issues, we, with the help of patients and families, started to essentially reimagine how we were going to work together, not just what we were going to do to improve the quality and safety of care in our organization. And because we became, we heard through a very deep and intensive engagement process, we heard from patients and families of concerns like as real as saying, we are afraid to come to your hospital. And listening until it hurts is actually one of the most important things that a leader can do. And what along with many providers and other patients and families, we found a positive energy out of that, out of those difficulties, where we decided to say, okay, if we really believe that our purpose here together is to transform the patient and family experience, we invited the people that were having the most difficulty with the experiences on the ground, both from a staff and patient level, to help co-create this journey forward. We didn't use the words, frankly, co-create at the time. Nobody was talking about the patient experience in the way that we do today, 7 years ago. But we decided that if we were going to get at the heart of changing behaviors, not just pronouncing rhetoric, if we were going to get at the heart of changing behaviors, we needed to get at the heart of how we made decisions about what impacted patients and families on a day-to-day basis. And to do that, we put a stake in the ground that said any decision in our organization where there is a material impact on the experience of patients, a patient will be at the table. Now, at the time, we really didn't know how this was all going to go. It speaks to the courage that that Hugh referenced of going to, if you're driven by the purpose and with some passion around what you know you need to achieve, but also channeling the fear of the unknown and the into something positive, and being willing to take a risk and work alongside those that you know are vital to that change process. It is incredible what can unfold from there. The journey has been one with lots and lots of lessons learned. There is no straight path. And I would say that some of the most valuable lessons along the way have been opening yourself up to those that have been most critical about the things that you think you're already doing well and ably. Having the voice of the patient and family at the table, then I say at the table in quotation marks, changes the conversation in a very deep and real way. And I'm happy to answer questions about that as we continue to go forward. The the thinking about this as it relates to the topic of today, what's been happening really is a fundamental shift in power. And this power shift is, to me, the most important feature of the change and the disruption that we're undergoing now. And if you think about the big societal changes, be it the Copernicus when he said to everyone who thought he was absolutely crazy that it's not the world revolving around the sun, but in fact it was the Earth that, it was not the Earth. I've got it all backwards. I'm getting it backwards. But you know what I mean, that the shift, that everything didn't revolve around the Earth, but in fact the planets are revolving around the sun. This was considered absolute heresy at the time. But through the combination of the science to demonstrate the value and the premises, to the convincing and the experience of people starting to work within new paradigms, gradually what is called a paradigm shift actually started to take hold. And now it's hard to imagine anybody thinking other than the fact that our solar system works in the way that it does. But these things do not change mindsets overnight. And in healthcare, my experience is that it is the lived experience of all of us in working in these new and different ways that will gradually unfreeze the current paradigms. And it's not without risk. Let me just go quickly to the 4 questions as a leader that I would add to the list that Hugh has already talked about, that in our experience at KGH, that are the questions that start to move us toward this new reimagined state of the way we work each and every day. The first is a leadership question that is about always seeing the people beyond the numbers. We talk about peopleizing the numbers at KGH, never resting with a statistic that you can't unpack and reimagine as a patient. Example, a patient who was at our infection control committee when the physician was presenting great statistics of progress around 0.08 improvement in our infection rates. The patient asked, how many people came to our hospital last month without an infection and left with one because we gave it to them? That is reimagining the meaning of hospital-acquired infection. And we work very hard to stay true to that way of thinking and then working through problems by peopleizing the numbers. The second question to ask yourself after, what does that really mean, that number, and how do I peopleize the numbers, is, have I included a patient today? Have I included a patient today in the issue that I'm bringing forward, in the problem I'm about to solve? If that problem and issue has a material impact on the experience of patients, a patient should be at the table. And there's many ways in which you can foster that active involvement and engagement, but it again changes. In our place now, I will not sign a policy that has an impact on the experience of patients unless the patient advisors have been involved and engaged, the patient experience council has been involved or engaged, and the patient advisory council will not be trumped by the medical advisory council. They are equal voices in solving problems and issues that address the very real needs of patients and families. The third question is, what have I learned from a patient today? It is a question that each and every one of you can ask yourself today, tomorrow. Ask your staff and your team members when you're on rounds. I have reimagined my role as a leader, as learner, as asking specifically, what have I learned from a patient today? And if during the course of my week I cannot connect to the answer to that question, I know I'm not spending my time in the right place. There's lots of sources of learning that we need to be creative about how to bring that, but ask yourself, what have I learned from the patient today? And then the fourth question is, how have I shared that story about what I learned with somebody else? And how have I shared a story of something that I saw that was an example, concrete behavior example of where somebody, some circumstance where patients and families were positively impacted by a reimagined behavior and interaction that that changed that experience in a positive and connected way. There are many winning conditions that need to be in place for this new state to be fulsomely embraced or within organizations and at the individual care level as well as at the policy level. And I look forward to talking with you about those winning conditions and other questions and comments that you may have. Thank you very much.
So Leslie reinforced and I think built on the question that I asked at the beginning, and that is, what do patients and residents need and how can the system respond? And she talked about the power of the patient voice. We talked about the need for a fundamental power shift and the need for new leadership. So the question was simple, and the answers are quite simple. So I guess the second question then is, what gets in the way? Because we should be doing this each and every day. I believe that what gets in the way each and every day is a list of contradictions. And I'm just going to talk briefly before we open it up for questions. I'm going to talk about two contradictions. And the first contradiction, and Leslie kind of spoke to it, is what I call systemic contradictions. The dynamics of technology, the rapidity of change in the external environment, and the burgeoning medical challenges associated with a society of abundance versus scarcity has changed the game of leadership. Social media, just-in-time decision-making, the explosion of knowledge, and media-dominated public discourse has altered the balance of power between formal leaders, the consumer, the public, and government. After all, change itself is the ultimate contradiction between our aspirations for the future, i.e. reimagining the roles of patient safety, quality, and patient experience, and the gap between that and our current state. Everything now is fast, and the ability to acquaint people with problems that need fixing, hence the demand for change in healthcare. Another contradiction, formal leaders may in fact wish to do the right thing, but are often hamstrung by current policy, procedures, ethical guidelines, privacy laws, that in some cases are artifacts of an age where knowledge was scarce. But as Leslie pointed out, knowledge is now in abundance. And often leaders, they feel that they don't have the luxury of a singular focus, that they need to maintain a focus on all aspects of the healthcare system on a day-to-day basis, firefighting, crisis management, and resist being whipsawed by variation in public opinion. Yes, informal leaders are often spurred by passion and common sense, and they are not hamstrung in their vision by policy, procedure, rule of law, etc. And often we see that creates a contradiction and a conflict between the front line, the middle management, and the top. So contradictions arise when two or three remain separate and isolated. And often we see that separation and isolation between the frontline space, the middle management space, and the top space. The other contradictions I want to talk briefly about is what I call practical contradictions, and they are legion. First, there is the operational versus the strategic contradiction. As service delivery entities get larger, senior leaders need to act more strategically and often pay less attention to the operational demands, the very demands in which they excelled prior to being promoted into those larger, bigger, far-reaching organizations. A second contradiction is that large-scale change that we're talking about here takes time. And unfortunately, the current turnover of leaders and realities of the existing political processes often don't provide that time to move the agenda forward. And therefore, it is a little wonder that clinicians and middle managers who are committed to an organization or community for the long term feel that they can wait the demands out for change that comes from the top. A third is the tension between collective accountability required for distributed leadership and individual accountability of designated leadership. I like the questions that Leslie posed as an add-on to the questions that I put in front of you. And I think at its core of the questions that Leslie put on the table is a very, again, simple pattern. First, we must ensure that we're all clear on the purpose of the work that we are here to do. And often I don't think we spend enough time with that clarity. We quickly rush to align the effort without designing the clarity. When you get the clarity and you begin to align the effort, then magic begins to happen in the enterprise, as Leslie suggested, when you do the power shift. Because with the power shift, you begin to build integrity in what you're doing, i.e. your purpose. But through that, you also begin to build a trust for the leadership. What I've seen far too often in the quality and patient safety space, we rush to accountability to measure without putting the foundational blocks in place, the setting of the table, i.e. the clarity of the purpose, the momentum, which brings you the alignment of the effort, the integrity in what we are doing, and the leadership trust. So Doug, now back to you for whatever questions and dialogue with the audience.
Actually, I'm just going to jump in once, very quickly so we don't lose the opportunity to just build on something that you said, Hugh. And with the contradictions, as you talk about, I think the point that I would reinforce, and from our experience at over the past 7 years at KGH, probably the thing that we did the best overall was have the absolute clarity through every piece of our every dimension of our organization, every pore of the organization, knew that the aim of the organization was focused on what outstanding care always and what that actually meant, and our commitment to the decision-making process of any decision in our organization that has a material impact on the experience of patients. A patient will be at the table. That clarity, and then the follow-through with saying, with making it real at every level, at the board, but most of all, I was way more interested in what was happening at the micro moments in the moment in the clinical space and at the organizational space than worrying about the big system or even the board piece. And so we really worked hard at making it real, learning and adjusting when it didn't work, and figuring out from there how it went. But I can't emphasize enough, as we've looked, and many others have come and studied what we've done, and 5 case studies have been written about us, and almost every one of the objective observers says in their conversations with people on the front line and patients and others that the clarity of the strategy and what we were doing and the consistency by which we built in all the connections throughout the organization has been one of the most important forces of change to build the continuous improvement along the way. And so just and the piece that I think I completely underestimated when we were going through this, frankly, was the response and feeling from staff that some who didn't feel as prepared as I thought they might in going along this journey. specific example, and I was out doing rounds, and on one of the units, a nurse said to me, Leslie, I completely get all this and support the focus on patients and families, and I can't argue with that, and I see how that's important. She said, but what about me? And I thought that was really, it really made me pause and think, because what we probably did was, I don't know whether we overbalanced, but we were so focused on absolutely everything's about the patient that some of the staff felt that maybe that was minimizing the importance of them. But underneath that, it wasn't about feeling valued. It was about feeling confident in their ability to contribute as true partners. And so when we dug under and learned, we discovered that there is work and very specific skills and abilities that need to be nurtured and developed in order to help people thrive in this kind of space and be true partners. So it's not something we can just expect to happen overnight. And mindsets and behavior modeling are things that all leaders need to shift and change. But I think we had underestimated what that takes. So that is part of the journey and the evolution.
All right. Well, you guys certainly started off this conversation with a bang. I mean, those are some great questions that have really, I think, hopefully started to prompt some conversation amongst our audience. We did have a comment come in earlier, someone asking if we should be seeing PowerPoint slides associated with that, and I told them no, we're not, because Leslie commented before we started that we're trying to free you from the bounds of PowerPoint so we can truly reimagine and think outside of the box here. So there's just the website is up on the screen, but there's not slides associated with this. We did have a comment coming in when we were, it's along this line of engaging patients, and this audience that you're speaking to, or that we're speaking to, is predominantly, if not entirely, from the child and youth healthcare world, and we're talking about engaging patients, and lots of people out there have family advisory committees and all sorts of programs to engage, attempt to engage families. This particular place in Vancouver is talking about having their family advisory committee. However, they face the challenge of getting parents to participate at the table during hospital work hours, as they're often working and trying to balance work and looking after their child, and they don't have time to participate or to be engaged by the hospital. In this concept of thinking outside the box, how do we reach out to those that particular population that has this unique issue of being parents of the patients, where you have, it's not just the patients themselves, it's the patients and the families. How do we reach out and engage them better in this process that you both have been speaking about?
So if I may start, I think that there are that challenge is not unique to the population of kids. I think that there are challenges with now, adults caring for their elderly and a whole variety of other dynamics around. First and foremost, we think about the notion of at the table is something that needs to be thought through very carefully and creatively. There are different levels. There's different levels of engagement. One of the things that we've done is really focus, and there's a great set of articles in the Health Affairs Journal from, I think, 2012, or 2011, that has a model, and it's called Cameron, C-A-M-E-R-N, that is the author of that, and that talks about a model of patient engagement that shows the difference of what happens at the clinical level, the organizational level, and policy level. They also set out a spectrum of involvement and engagement, and part of the work is to figure out what makes sense for that individual and the organization. So there's a continuum of consultation, involvement, as well as the partnership and shared decision making. And part of the first and foremost is to really hardwire and think about what is your model of care, and that's where you need to start. And thinking about the focus on the premise of saying, if you said that we are actually going to embrace that nothing about me without me philosophy of care, it really flows from there then to have the family plan and the family and patient plan that is going to be built around where people want to fall into that spectrum of engagement and how they are going to work. So we're trying to get rid of, example, of even the language of doctors' rounds. So they are patient-family rounds. So the work and it's important in our model of care, which has 5 features, the discussion and involvement and engagement of the family in that is one of, you have to demonstrate evidence that that's happening in order to be deemed, quote, compliant or demonstrating those commitments. So I'd say do the work on the ground first. This is really, really important. Know your why people you want people engaged, and sort out your models of care. I do know that a group, and there's people on the line from CHIO, I think that they've done, I just happen to be more familiar with theirs, they've done some exceptional work on patient family engagement and really have some leading practices and a lot of lessons learned. So that may be helpful from your specific population. But if you go forward with this and you're thinking about patients and families as tokens or as, which I know nobody wants, but it's so easy to fall into that trap. Start with the notion of nothing about me without me. And think about shifting from doing for and doing to doing with. And if you think about that as the start and then design your processes and your practices from there, it will flow and you will find ways to connect the right people, the family, the caregivers, those that need to be involved in the decision to the decisions. And it might mean that you are shifting and changing the practices. In fact, it will mean you are shifting and changing the practices of the providers, potentially when they're doing rounds and those kinds of things, in order to be truly patient and family centered.
It's Hugh and I. In the question that was asked, I think there was what I interpreted was another question, and that is, healthcare is a 7/24 business. Patients, families are busy. They work during the day, or they're providing care to people during the day. So how do they free up their time to be part of the engagement process? When typically, I'm just saying typically, in healthcare, the majority of these meetings take place Monday to Friday between 8 and 5. And so I think there are all kinds of ways, going back to Leslie's point, be clear on what the engagement looks like, and there's all kinds of models. But also I would urge people to look at new technology, just like we're doing here today. You don't always have to be face-to-face. And so really be creative in your approach to widening the circle. Dick Axelrod, many years ago, wrote a great book on basically appreciative inquiry, and he talked about the key starting point for all engagement is the wider the circle, the better the input, and at the end of the day, the better the result. And I don't think we should be hamstrung by the fact that most of our activity takes place in a Monday to Friday framework between 8 and 5. If we truly are about nothing about me without me, and it's no longer a philosophy we aspire to, but it becomes the reality of day-to-day practice, then I suggest organizations got to stretch in their creativity of what are the processes and the mechanics that they're going to use to make that engagement take place.
Early on in your presentation, you were talking about as we went through this patient safety and quality improvement journey over the years, perhaps we were too focused on the data and collecting numbers and forgetting about people. One of our audience members commented that perhaps it was that the focus was on management collecting data and excluding the patients from that data and not allowing the patients to access data and looking at that from a safety perspective. So empowering the patient by collecting the data and giving them an opportunity to use their own data. Is that a part of the issue? Is it's not really an issue of collecting the data that we've ignored the patient in this data collection?
I agree. I mean, Leslie and I had the privilege and fun to write an essay for Longwoods, and it was basically titled "If We Had a Magic Wand," and its whole focus was on the future. And I'm just going to read you a small snippet of this essay, which I think addresses the question you raised. We said, in the future, everything becomes portable. Location doesn't matter, presence does. Connections with families, patients, community services, peers, specialists, even hospitals will be dynamic. Pharmacy apps will allow individuals to take charge of many aspects of their health that previously required a series of professional interventions. Systems that require you to physically travel to specialists only to wait for access for someone else's schedule will be a thing of the past. Just look at how consumer preferences, big data, personal technology has revolutionized the media, the entertainment, and retail sectors. Some say healthcare is different. We think not. And so I agree. I think the future will be the patients, the residents, having their own data. I found it fascinating in the National Post this week, the president and CEO of TELUS has a huge vision. And what's that vision? He says updating health is his next goal. Why? Well, TELUS today is currently the largest repository of healthcare data in the country. And I believe that the future that they're looking at is now how do they connect that to the new technology where now the consumer will be in charge of and have access to information.
And on the ground, kind of the day-to-day pieces of decisions you can make today to help advance the involvement and engagement of patients and families with data is thinking about again, what's the purpose of the information. So everything from at the clinical side, if there's a plan of care that needs the commitment and the design of every one of your processes is around the nothing about me without me, then be it the ordering of tests, the interpretation of what the data is, the access to the information, that you open that up for patients and families, and you include them in that so as it relates to them, and making sure that from a model of care perspective, you're putting you're translating the commitment to nothing about me without me by the very way in which you handle information and involve them. There's a big move going on both in the U.S. and now more slowly in Canada, but around patient access to data. And there's some about their health and their health records. And there's a movement in the U.S. with some people that I've gotten to know very well as real activists that are saying that access to health data should be a civil right, and that there isn't an example of any other data that any of us have that is not accessible, and that it should be a fundamental civil right. And you can, before finding out how to change the world like that, you can make very concrete choices in your own organization around how to have people contribute. There are examples in where people do support patients and families charting in the chart, where they're putting their information or the use of the whiteboards or others that be about information sharing for the purpose of improving coordination and safety of care. And there is lots and lots of evidence of how data and information about the patient from the patient, based on what they think the team needs to know, can dramatically improve safety and reduce errors, etc. So you can make it very practical on the ground, as well as doing that, peopleizing the numbers, and and educating the public about what's going on and the patients and families of what's going on with data and waiting times and other things in your own organization. And there's lots and lots of examples of organizations that do that really well.
And Marcel's put a comment in that says, my data is private, yours is not. And by yours, he's referring to the hospitals, saying that I'm safer when I know the number of adverse events, the outcomes of quality improvement initiatives, hand washing rates, etc. So I think he's commenting on the fact that hospital, again, supporting a lot of what's been said here, hospitals being more open with their information makes quality improvement happen and makes everyone safer.
I'll give you an example of where the power of exactly that great observation played out in our organization. We had a really, really tough time with infection rates. We had the worst infection rates in the province 6 years ago. And we had also a 34% hand hygiene compliance. And so one of the things after we had a patient death where a patient died of hospital-acquired infection, that there was we decided to really put that into a real teaching moment for us and a call to action to revitalize our focus on hand washing as one of the most critical, vital behaviors in keeping people safe. And we went to the Patient Advisory Council for help of what else could we do. And they said, why don't you just put a chart up when you go into every unit, before you walk into the unit, what the hand washing compliance is on that unit. And so that was one of those simple, brilliant ideas, rather than the chart that I'd have to go if I was doing rounds or others and go and find, and where was it pinned up on the wall behind something else around what the hand washing rate was. And we look at both from a category of staff as well as each unit, and then organizationally. But it's the organization and the unit-based rates that are posted in public areas, and we encourage conversations. And I'll tell you now, our hand washing is at 92%. We've actually dropped down from where we were. We're kind of kicking that back up again. But the engagement and involvement of patients, and when we do orientation now about protocols and hand washing, and the commitment to one of our strategic directions, which is eliminate all preventable harm to patients. That eliminating all preventable harm includes hand washing, and we've reframed the storytelling and the way in which we talk to patients and families, and saying that, if only 6 out of 10 people are washing their hands, that means in our world that 4 out of 10 people are intentionally harming patients, and our goal is to eliminate that preventable harm. And we're encouraging you to speak up as well as encouraging the progress with patients. So sharing that data, making it more public, and tying that to a specific goal, like eliminating all preventable harm, can help create conversations where learning takes place, behavior change, and improve safety and quality.
Doug, just building on Leslie's comment and a great observation from one of the individuals online, I'm a firm believer that using transparency, and I guess we can move to comparative reporting, really pushes on the journey in a search for truth, and truth begins to shift mindsets and behavior. And then tying that into a sound accountability stream, the accountability can be very powerful, what I would view as a disruptive catalyst to knock us out of our current complacency on patient quality and the patient experience.
We had a comment come in earlier about both of you have sort of referenced the power shift and I think you both have commented that the power is shifting more towards the hands of patients and families. They were asking, the question was about how do we facilitate that power, or how do you see that power shift playing out in the future? Do you see it being a facilitated transition by healthcare organizations and the establishment, or do you see it being driven in an unfacilitated way, maybe not quite as clean from patients who are becoming more and more demanding? And I thought, Leslie, that it becomes even more complicated as we shift the power into the hands of the patients. When you made the comment about when you were on your rounds talking to people on the floor, and one of the staff said, what about me, sort of thing, as we shift this power more and more, like how do we facilitate this in a way that we can make a smooth transition as the power shifts without disadvantaging the clinicians and staff in hospitals, and still making the appropriate balance of power in the relationship?
So this is about shared power. This is not about, and all of our patient advisors and would say, and we now have like 65 patient experience advisors at KGH involved in every aspect of the organization, in addition to a variety of other our patient advisory forums and others. The people would say this is not about kind of giving over power completely. It's not about the provider saying, I'm going to give this power or that power, because that notion is very paternalistic and hierarchical, and it is about shifting to what people in the broader sphere of society talk about as the new collaborative economy. And that's kind of a pretty big word and notion, but on the ground that plays out by the mindset and the practice of the patient and family as the lived experience experts, and the providers as experts in what they have to bring. And it, in fact, one of my colleagues from the Netherlands, Lucien Engelen, he's just done some brilliant work and in this area, and he talks about the shift from the ego system to an ecosystem of health, and he builds on what's happened in other industries. So the way retail, the way other books and online shopping and all these other pieces of industry, banking, has completely shifted so that the voice and the power of the consumer is considered on a much more equal basis, as opposed to the traditional I know best. So we're seeing that happen around healthcare, and people are expecting that to happen. We have people, though, we need to remember, are in very vulnerable states often, feel very vulnerable, and when they are when they're sick. But if we construct the basic premise of you are an expert in your life and your condition, and together we are going to solve this issue or challenge that's facing you, and we're going to do it on your terms. That is the power shift that needs to happen. So it's behaving and embracing the collaborative, equal, that the expertise is shared and equal and not hierarchical.
I would completely agree. I mean, again, trying to be simple, I like to break complexity down into its bits. Fundamentally, from my view, a health system or an organization is really a web of relationships, conversations, and decisions between people, between healthcare providers and patients and residents. And so that, to me, then pushes us to a shared responsibility. It's not about power of one or power of two. It's about the power of the collective. A couple of observations, however. In my orientation to the role of CEO of the Canadian Patient Safety Institute, I became a patient for the first time in my life, and it has changed everything. Because I felt what it's like to be in a bed, on your back, scared, losing my power, and incredibly vulnerable, and yet I'm an informed consumer. But my voice went silent for the first couple of days. So that's my first observation. So, and Leslie touched on it. But the other observation is when I began, then when I knew I was going to live and began to have conversation with staff, I also realized a second aha, and that is we haven't prepared staff for the new conversation with the new informed consumer. And I love this story from Leslie's hospital. It's from Karen Nicole Smith, who's a patient safety advisor. And this is her story. She says, I am the one living with kidney disease, doing my dialysis, waiting for a transplant, and managing my health risk every moment of every day. I see you, the system, for about a few hours a month, which is a very small percentage of my life. The rest of the time, I am on my own, and the managing of my personal situation is up to me. Like other empowered people, she is clear of the roles and responsibilities and the values of the experts, and that they have a critical role to play in her circle of life. But while the experts come and go, she is the one constant in her healthcare journey. And she says, quote, "I have come to realize that I am a lived expert, and together with your expertise, we will be a formidable team." And I just love that because I think it speaks to what Leslie's talking about. It's not a power shift to one, it's a power shift of mutual respect for what everybody brings to the table.
We do have only we only have one quick question left. If anyone else has any other questions or comments they'd like to put in, please get those fingers flying on the keyboard now. The only quick question that we've got left on our list was from Tanis and Hugh. She was asking, you mentioned Dick Axelrod's book. I believe it was about appreciative inquiry. She was just wondering what the name of that book was.
Continue. I have a moment here. It'll come to me.
All right. Well,
I'm going to walk into my library and see if I can find it.
Okay. All right. And I don't see any other questions.
If you want another great book that really gives a glimpse of the future, the book by Eric Topol it's called "The Patient Will See You Now." It is just a beautiful and very incredible book about the changing dynamics of the patient and the consumer in health and in transforming, literally, like turning healthcare on its ear, disrupting it. And what I really like about the book is it gives really practical examples of what's starting to happen already and what it means for providers, the system, policymakers, and others. So it's a very eye-opening read that I would encourage everyone who's interested in this shift and change. And he links it, Eric Topol does, who's a cardiologist, he links it very much to the world of, to his experience as a physician.
So the book is titled Terms of Engagement, Changing the Way We Change Organizations. It's Barrett and Kohler, 2000.
All
and
right.
It's Richard H. Axelrod, A-X-E-L-R-O-D.
All right, thank you very much. And Eric Topol has lots of videos on YouTube. He's done TED Talks and talks at Google, actually, that they've published on YouTube as well. So you can always find lots of great things from him.
The other thing, if I could just suggest, and we are but one organization that's done a lot of work in this area. More and more resources are coming out on engaging patients and families. Certainly at our KGH website, and our teams have done just such an extraordinary job. I'm so proud of everybody at KGH, the patient advisors and our teams that are really been breaking new ground. So you're welcome. We give essentially it all away for free. So there's resources, how to select advisors, everything else, and you can just go on that and adopt and change. And we just ask that you help us understand what you've learned. And the Canadian Foundation for Healthcare Improvement, CFHI, has been doing studies, and there are 22 collaboratives that are underway right now, right across Canada, where there's very active learning about how to engage patients and families for improving quality and safety, and it's just terrific resources. So I'd encourage you to look at CFHI, and of course also the Canadian Patient Safety Institute has been doing some terrific work with the Patients for Patient Safety and others, and they are really good, I think, CPSI, of really bringing to life some great stories about what this means and how to kind of get this happening in very real and concrete ways.
All right. Well, I think we've exhausted the comments, maybe even exhausted the audiences as they've been out there reimagining. So maybe we'll wrap this one up. Oh, sorry. Go ahead, Elaine.
Thank you. Sorry to interrupt, but I do have one question. First of all, just a comment. Leslie and Hugh, thank you. What an amazing conversation. Just just very, very insightful, and I'm certain that everyone on the line is continuing and will continue to reflect on many of your comments and experiences. Just Leslie, if I could refer to just one thing that you had talked about, the micro space, or at the clinical level. That, I think that among many is such an important comment that you made, and I'm going to say strategy that that KGH implemented as part of the work that you've done. What were the challenges, though? I can only imagine, but if you could highlight some of those challenges that you could share with us.
Well, I think that I think that the most important challenge was, the work. I think the most important foundational work was really around the model of care, and the teams involved patients and families in the design of the model of care and coming up with what are the standards that we expect and we're counting on people to uphold. And then taking each of those standards and ensuring that there were very specific behaviors and actions that support those standards, that people were supported in learning about and fulfilling those standards. And there are. I think that the challenge is when you start to have new things, even something as simple, what is now we look at as simple as opening up visiting hours, restricted visiting hours, which like a lot of hospitals, we had big restrictions on visiting hours. And now it was the patients and families who, again, that listening till it hurts, it's a hard part around them saying, this doesn't make sense. We have a 3-page policy on defining who is family. They said, family is who I define it as. Like, who are you to define that? And you kind of go, yeah, that makes a lot of sense. And then they talked about the value of presence of family and in the healing and the outcomes of care and the experience of care. And we moved to support change in policy now 6 years ago to open up all restricted visiting hours. But one of the biggest challenges there, even our Nursing Advisory Council, we had such hardwired the processes and the practice of, the 9 o'clock overhead, everybody go home, and then that became the time of when, quote, we do our work. Well, we needed to really rethink and not make this change like an add-on or a problem, but it started to fundamentally change. Some areas, people said, well, finally you've caught up to all the things that we're secretly doing and breaking the rules. Right. And other people said, this is really going to require us to work quite differently, and then working through that on a unit-by-unit basis. Yeah. And involving patients and families in the design of the change, as well as the delivery and the evaluation. And it takes the courage of our leaders and people to really and clinical champions and others to be open and talk about what they've learned and how it's gone and what they would do differently. Mm-hmm. And it can't be an add-on. It needs to be fundamental shift to how you work. And now we see such great examples of people who are, Kelly Kitchen leading the operating room in our pediatric program is now talking right. about, instead of looking at informed consent, they're looking at informed choice. They're right. looking at, and so they'll start to raise questions. So you just keep going, and you just keep moving and learn, and don't let up, because if you truly believe in the power of the patient voice, and you have committed to nothing about me without me, you need to uphold that at every step.
Right. Leslie, if I can just make a comment to that. First of all, thank you for that fantastic sort of, again, additional insight and sharing. But first of all, KGH and Hotel have been members of CAPC of our organization for many, many years. And of course, we work very closely with Kelly Kitchen from KGH. So I think, and I hope there's going to be many opportunities in the future to continue to share some of the family center, family engagement, I'm going to say best practices and policies that you've implemented at KGH with other member organizations and partners across the country, and just have an exchange very similar to what you and Hugh have done today, but maybe we can have an exchange with KGH and other healthcare organizations within CAFC's community.
Sure, because there's great examples of terrific learning, and those are the kinds of conversations that help spur on progress and learning.
Absolutely. So thank you again, and Hugh, a great big thank you as well.
All right, thank you, Elaine. So, like I said, that's the end of our questions and comments from the audience. So I think it's maybe time to wrap this up. So we'll hand one last time over to Hugh and Leslie for anything you'd like to close this session off with, any final closing comments. So, Hugh, maybe we'll start with you.
Well, thank you, and again, thank you for the invitation. Hopefully, what Leslie and I collectively have been able to paint is a picture that there's an opportunity before us to reform the Canadian healthcare system to achieve its purpose of improving health outcomes. And I think to do it better than any other system in the world. I believe that the skills, the power, and the passion required to meet this challenge are today present in abundance. And it's up to leaders to go find it, to mine it, and to surface it, including bringing the patient, the resident, and the family to the table. So I say, and I end with this, the patients will see you now. Are you ready?
And I'd like to really close by saying, seize the moment. And if there's things that we've talked about and where you're learning from others or you're trying from yourself, just do it. I mean, we did not have a grand plan. We had a focus. We were deeply committed to the outcomes and of transforming the patient and family experience. That was our unifying force, and that we saw as the reason for everything else that we were doing. And we just started looking at everything we did through that lens and making change by change by change. And this is, our process was very organic. We did not have a grand set of Gantt charts and plans right from the beginning of how everything was going to look over the 5 years. What we did, though, is said by the end of that 5 years of our first cycle of strategy, that we would be living our commitment to any decision in the organization where there's a material impact on the experience of the patient will be at the table. And I'm so proud of people who have done that and learned along the way. And I'd encourage you to just do it. Get in there and embrace the opportunity and the changes and make it real in very small, concrete steps. You don't need to change the world, but you will change the world of an individual patient and their family, and there is nothing more important than doing that.
Thank you, Leslie, and a great way to end this conversation off. I think it's certainly been one of our most diverse audiences that we've ever had. People from children's hospitals in Ireland, England, Australia, across the United States and Canada, all hearing that message. So I think we've got an army of people that have been invigorated to go out and just go for it, as you said. So I think that's fantastic. So thank you to both you and Hugh. It was you led a really great conversation, and I'm sure everyone appreciated it. And thank you to the audience for all of your participation. It's always great when you guys can come. We do our webinars every Wednesday at 11 a.m. Eastern Time, and it's always great, as I mentioned, if you can watch live, because your comments and questions really enrich the discussion. But when you can't watch live, we do record these sessions and make them available after the fact on the Knowledge Exchange Network. We'd also once again like to thank our colleagues from Mallinckrodt Pharmaceuticals, and once again mention that They will be hosting a session at the CAFC Annual Conference in Quebec City on October 19th, a sponsored breakfast session where we will be hearing stories and learnings from the front line, the impact of interdisciplinary teamwork on patient safety, healthcare and practice, and we'll be hearing from Dr. Keith Barrington and Ms. Sophie Gravel from the CHU Saint Justin in Montreal, and from Ms. Barb Farlow from Patients for Patient Safety Canada. And they really see that session there as sort of part 4 of this series to sort of wrap it up as we are reimagining the system and looking at how patient safety has advanced over the years. They really want to take all of what we've heard in this series and bring it to the grassroots that will be at the CAFC conference and talk about what your role might be in the future of patient safety, your role as clinicians, as patients, as families, as stakeholders in the healthcare system. So we hope we'll see lots of people there at that session in Quebec City. We do have a bit of a hiatus. This is our last webinar until November 4th. We'll be coming back because of the CAFC conference. Lots of things happening there while we're preparing for that conference. We won't have any webinars until November 4th, and we'll be coming back starting in November with a start of another small series on using social media in children's healthcare and children's healthcare research. We've got a session on obesity, hearing from our colleagues at the CHIO Halo program at the CHIO Research Institute, and lots of other great stuff coming up. So thanks again for joining us today, and we hope to see you back here following the CAFC conference in November. Hopefully we'll see you then. Bye.